Good morning, everybody, and I hope everyone enjoyed day one, and we're delighted to be opening day two. So thank you very much to Nolex and to everyone for having us here today. So we're going to present to you a project that we have done in Swansea Bay University Health Board, looking at the role of point-of-care testing, specifically for CRP in primary care. So it's a real-time, real-world, general practice, pan-cluster project that we have undertaken over some 18 months. Just to set the scene, Swansea Bay University Health Board has a population of around 390,000 patients, and you will not be surprised to hear that we have quite a high prevalence of COPD in South Wales, largely driven by industrial history and probably smoking as a lifestyle choice for many of our residents. Within the Health Board, like a large parts of England, Wales is working in cluster groupings within each Health Board. And clusters, for those of you who haven't heard of them before, are groupings of GP practices, dentists, pharmacists, optometrists, community pharmacists, and also other healthcare professionals working together with the aim of equity of provision of access to services and also delivering services according to local needs alongside our contractual obligations depending on what one does within the cluster group. So moving on to the next slide. I've set the scene with the background to why we felt that it was important to look at a pan-cluster project, in that we wanted to see whether or not CRP had a role within general practice consultations and whether or not the learning we could get from this project could then be shared wider. So the issues is that antimicrobial resistance is high. This is not peculiar to Swansea Bay Health Board. This is a problem across the world. Indeed, the World Health Organization and G7 have already devised many policies and policy documents, statements about how they want to address this and reduce it. But also within Welsh Government, like English Government, there have been a number of standards set and 5-year policy documents around antimicrobial resistance and ways in which we can all work together to try and reduce it, and some standards set on what they expect us to achieve within Wales. It's worth noting that Swansea Bay has always had a very high infection prevalence. We have the sad label of being the highest C. diff prevalence across the whole of Wales and actually across the UK as well. We have also had quite large issues with antibiotic resistance, like many parts of the UK, to trimethoprim for UTIs, but also specifically in Swansea Bay, we've got issues with coamoxiclav prescribing and resistance to that. We have high prescribing of antibiotics compared to other parts of Wales. So all of this contributed to us identifying that a project looking at ways in which we could support clinicians in potentially reducing their antibiotic usage, and also look at ways that we could change patient perception and their expectations of antibiotics would be something that would be very useful, and where the role of diagnostics could support that agenda. So we looked at a number of diagnostics that were available, and we identified that actually CRP would be something that would be very useful for us to potentially have in practice. Currently, if you don't have a point-of-care CRP machine, you have to organise a same-day emergency appointment in the hospital. They have to go down, have a venous sample taken. The result comes back maybe later that day or the following day. But having immediate access to it can actually support clinical decision-making and, as I said, explaining to patients why they may or may not do it. But we thought, well, okay, it's fine having a diagnostic test available, but where's the evidence to back that up? And we were hearing that a lot of practices were having CRP machines and using it for every sort of infection coming through the door. But when we looked at the evidence base to support it, we have found a number of trials, including the PACE study, which showed that it was really a strong and robust evidence base for the use of CRP in lower respiratory tract infections as well as infective exacerbations of COPD. Therefore, we felt there was an opportunity to see whether or not, if we restricted use of it to those presentations, would this actually change our prescribing performance? Would it change the way we practice clinically? And what would be the impact on patients? So the study design. Here you'll see that we have the aims and objectives. The primary aims was to evaluate whether or not the CRP test itself affected our patient management decisions, and therefore by corollary you'd expect it to maybe reduce antibiotic prescribing. So we looked at a range of practices. We chose 11 diverse practices across Swansea Bay University Health Board with a varying degree of different demographics, different prevalence, different deprivation of sort of respiratory illnesses, and we chose them to represent a clear cross-section of our health board. So as well as looking at whether or not CRP would be a useful diagnostic test to have within practice, we also wanted to look at the actual impact on prescribing. We wanted to look at the clinician experience to see whether or not it was actually something that could be delivered and user-friendly within a practice. Certainly busy GP practices experience quite challenging workload volumes. We wanted to look at the patient experience and the acceptability of having this test as part of their consultation. And of course, they're not forgetting the cost implications. We all have to use our scarce resources judiciously and prudently, and whether or not, again, was there a place for this test, and if so, would it be of value to everybody or just some people? So we set up the study outcomes looking at, did it have the impact on prescribing that we were initially hoping to see, and then we evolved it into, as I said, clinician experience, patient behaviours, etc. With the end point being that if it wasn't going to be useful for all practices, was there actually a framework or a checklist that would be useful to commissioners or individual healthcare practitioners and organisations making these decisions to make it easier to determine that this would be a useful test for them to potentially have available to their team. So to deliver the project, we set up a task and finish group that had a wide range of professionals in it. We were lucky to get really good support from the health board. We had our IPC teams involved. We had our point of care teams involved. We had project management. We had our medicines management team, and also the clinicians and myself as the primary care lead for Swansea Bay Antimicrobial Stewardship. We had a standardised operating template which was given to all practices, along with a quick summary as a quick aide-memoir for them to use after they'd obviously digested the enormously long SOP that I'm sure we're all used to seeing. They all had training in practice from the point of care team on the use of the machine. They were all given they all agreed to have a template imported into their clinical systems, which would capture the data, and they were given regular support one-to-one and through quarterly feedback that we were then responding to the needs of the practices. We devised some patient questionnaires which were available in paper format and also via text and electronically, so that we could get patient experience and views back from. And we also asked if some of those would be interested in doing sort of further interviews with us at the end of the study. So as I said, it was a multidisciplinary team working project, and we had really good buy-in from the practices involved. Not every practice needed a new machine. Some practices had the machines but weren't using them, or were using them in different ways, and some practices had them new. So if you had a new machine, you had the full training experience from our point of care team, but if you'd already had the machine in your practice, you just needed to have refresher training, because obviously if we were purchasing the consumables from the health board, we wanted to make sure that everybody had the right training and were using them appropriately. So we go on to now the data collection and the analysis. So essentially the prescribing data for the participating practices was extracted using the Casper audit tool, and then this was correlated with information from the practices, so the extracts from the IT templates they were using, cross-correlated with the log tables that were also next to the machines, which to make sure that we were tallying up the use of who had the test with actually the outcomes of the test, and then obviously our prescribing data. It was an enormous piece of work, but it did allow us to have a comparative analysis of prescribing decisions following use or non-use of the test. So I'm going to hand over to Dan Robbins, who is an antimicrobial specialist pharmacist within the Swansea Bay team, who, if it hadn't been for Dan, I can absolutely assure you that the data wouldn't have looked as good or as tech wizardry, which is absolutely amazing. So I'm going to hand over to Dan.
As Charlotte has already alluded to, we were looking and interested in prescribing of respiratory tract infections. And within Swansea Bay, within our guidelines, we would ordinarily be using amoxicillin, clarithromycin, and doxycycline. So what we can see here is that each one of those lines represents one of our GP practices within our health board, and this is pooled amoxicillin, doxycycline, and clarithromycin prescribing. So I hope you're all ready for a lesson in statistics at 9 o'clock, and there'll be a test at the end. So what we can see here from all these practices, there's a huge variation in prescribing. We can see there's seasonality within this, and we can see right in the center there was a group is strep outbreak that a lot of us experienced, but particularly within Swansea Bay as well. So because there's such huge variation in prescribing across all these practices, it makes that evaluation quite difficult. It's very difficult to pick out whether our point-of-care CRP testing has actually made any benefit or any reduction in the prescribing. So this is all practices, and what I wanted to show you here, so this is the 11 practices that, that we have evaluated, and even within these 11 practices, we can see huge variation in the prescribing there. So we went live with the intervention about here. So if you were to look at that, it'd be quite difficult to pick out whether that has made any difference to prescribing trends. So what we have, so as I just said, big variation in underlying levels, trends, seasonality, peaks and troughs. So what we cannot do is simply evaluate percentage changes as an indicator of the intervention, because ultimately everyone is going down anyway over time. It's quite difficult to pick that out in that graph, but they are. And they are all experiencing seasonality at different magnitudes, etc. That's the background. So how we've done this then is we have used synthetic control modeling. So what synthetic control modeling does is that it will plot our practice of interest. So that is that solid black line that you can see. So this is just an example synthetic control, just so I can show you some of the data later, but just to kind of set the scene for you. And then what it does is that it looks at the non-treated practices. So these are practices that obviously weren't involved in the intervention. And it uses an algorithm to pick out the optimal weighting of those non-treated practices within the pre-intervention period, so pre-intervention, before we've actually implemented CRP, to see if it can get a good match, a control. And from this then, we can then evaluate whether in the post-intervention period, our treated unit, so the practice that have been using the point-of-care CRP test, does deviate from what we would have expected anyway. So now we are able to control for seasonality, we're able to control for autocorrelation, we're able to control for those general kind of downward trends that we're seeing over time anyway. So what we can see here is that we're achieving really good matches with the control. The model is doing what it should do. We can see the point that we've gone live, and within this here, we can see a deviation from what we would have expected based on how other practices within Swansea Bay have progressed within that time period. I won't dwell on this too much, but what I wanted to show you then were some of our results then in using this model. So as Charlotte already said, we selected 11 practices, and those practices were given the opportunity to use those point-of-care CRPs within their clinical practice as they felt fit. Okay, so some practices decided to use this for every presentation of respiratory tract infections. Some of them decided to use it more selectively. So there was a big variation in how practices were implementing it, and we see this in the results as well. So what I wanted to show you here were 2 practices that were enrolled, but they were unable to use the machines for various internal pressures and challenges. And we can see we get a really good control match, and we see no deviation then in the post-intervention period, what we'd expect, because they weren't able to utilize the machines. And then when we compare this to practices that did manage to embed these machines into everyday consultations, this is what we see. So we can see these divergence in the post-intervention period from what we would have expected their prescribing trajectories to look like. And we can quantify that as well. So there we are. So this is what we've managed to show and what we've managed to demonstrate. So those practices, those few practices that were able to embed them into practice, did demonstrate reductions in their antibiotic prescribing from what we would have expected. There we go. I think that's everything that I need to touch on. I'll hand you back over to Charlotte.
Thank you. Thanks, Dan. So as Dan has said, we found it really useful to give practices the flexibility in how they could use the test, because we wanted to know, really, we can mandate everybody had to use the test, but actually, was that actually going to be the reality if this were to be used more widely? So we then moved on to getting clinician feedback. So we've seen the data, which does show that if you use the test reliably and regularly, there is a reduction in prescribing. So what do clinicians feel of it? Well, a lot of clinicians actually said it helped to guide their clinical decision making. So, we all have seen patients where they've got a terribly chesty cough, they sound really unwell, but when you listen to their chest, actually it's very clear. And sometimes having the CRP would give you that assurance. Within Wales and some of the practices we chose, there was a real sort of historical expectation of having antibiotics. So clinicians said it really did help change some of that narrative and educated patients sort of very helpfully. Practices also said that clinicians found it useful for particularly COPD exacerbations, where classically you'd give antibiotics and steroids. So we were seeing a shift then to just using steroids where it was appropriate to do so. And as I said, they had a few surprises. So a few patients who didn't look that unwell, they clearly had a chest infection, they did the CRP and it came back unexpectedly high at over 200, leading to an admission, which perhaps they wouldn't have felt was necessary at the point that they saw them in the surgery. So that was all really, really interesting. So, but it wasn't without its challenges, and we were expecting that because we didn't, nothing's going to go hunky-dory. We anticipate things ahead of time. We try and work out, what could go wrong, what's going to go well, etc. But we knew that there would probably be some hurdles to overcome as the project went on. And I think, as Dan has alluded to, I think clinician engagement was a particular challenge for some practices. So you'd get extremely good buy-in from some who really saw the value of it, and others who thought, oh God, this is just going to add to my consultation time, or it's really busy in surgery today, I don't have time to add that in. So as I say, it was challenging during busy times. We did run it over a winter period, but we found ways of helping practices maybe look at how they were implementing the test, and I'll come on to that in a minute. As I said, a limited clinician engagement, time pressures, HCAI, the availability of some of the healthcare assistants and nursing slots, so not every practice had ready access to that, perhaps in their branch surgeries. As Dan has said, two practices had some internal issues, which meant that they weren't able to utilise the test. But again, that was really good for us when looking at the data. Patient feedback, so we were really lucky. So this project covered practices covering around, say, 90 to 100,000 patients involved in the practices. And we had over 600 responses from patients. It was incredible, really. And so many of them wanted to speak to us further. But some of the feedback we had was they were so sure I'd be given antibiotics, but now I understand the dangers of using them when you don't need them. So it stimulated that conversation about why antibiotics can be harmful as well as helpful. The clinician explained everything to me. CRP result was below the level for infection, so I didn't need antibiotics. They were saying, so they were clearly showing that they really, really understood what, the test was about and why it was being used. So from this, our key messages and findings were that, as Dan has said, practices that utilised it consistently and regularly for the right patients did have statistically significant reductions in respiratory antibiotic prescribing. Clinicians did say that they described it as a valuable diagnostic tool for confidently ruling in or out infections. The test supported clearer decision-making. There was a shift from routinely giving antibiotics and steroids to patients with infective exacerbations of COPD to maybe just steroids. The CRP results facilitated effective patient communication, and that over the course of the project, practices found increasingly flexible ways to utilise it if they weren't utilising it in every potential consultation where it could be used. The negatives, as I said, time constraints, that was the biggest one reported back to us, and the additional steps required. So for some practices, they would do the triage over the telephone, then book the patient in for a CRP test, then see whoever it was who was going to be doing the examination. Other practices saw the patient went for a CRP test, came back. So some of them felt that it was adding an extra step. Some reported that the time involved is only 3 to 5 minutes, but when you're really busy of a day, that 3 to 5 minutes is quite a significant time impact. And one or two practitioners actually felt it didn't really aid their prescribing decisions. But when we correlated that back to the practices doing that, it was the ones who weren't using it very often at all. So perhaps if they had got on board, they may have found it different. But, you know, again, really useful learning. So key outcomes. It is feasible to reduce your antibiotic prescriptions from using this test. It is a test where it can be really useful in the right practice and having the right clinician engagement. It's not cheap, though. It's cheaper to just give a prescription for the antibiotics. It's cheaper to just give what patients want. You get less complaints. It's not the right thing to do. And I think what we've shown from this project is that the right thing to do is to allow and enable where tests, diagnostic tests like this point of care CRP test is to be used smartly, usefully and effectively, that it can help us all in our work to reduce antimicrobial resistance and to improve patient quality care. So we have gone on to sort of next steps, which is Swansea Bay are looking at the outcomes of our project to see whether or not they can afford to continue having it available to practices, and if so, which practices, and should it be extended more widely into our community pharmacies, our out-of-hours teams, our virtual ward teams, and our acute clinical teams. You know, how does, there is a Welsh Government project going on called Sparrow, which is about to start. How do our findings fit with that? We would like to explore other options for funding, so we're hoping that the findings from this will be useful in order to support all clinicians having access to all diagnostics that they need, and we're looking to publish our findings more widely. But one thing we did learn was that perhaps we didn't expect the project to evolve quite as significantly as it did with all the extra outcomes, so perhaps we should have sought research approval ahead of it and ethics approval, something we're trying to do in retrospect, which I would argue is really not the right way to do it. And we'd be happy to take questions afterwards. So thank you very much for having us here today.